air, just like you're stepping and walking. All of your, gonna do a little bit more of your leg exercises. Can you try some more? And down. Now your left leg up.
It is really important to focus on falls prevention and also injury from falls because, number one, it is the most frequently reported adverse event in long-term care facilities. In addition, about 40% of admissions to long-term care homes are the result of a fall. And following that, at least half of residents in long-term care facilities do fall. And when they do fall, most often they do end up with injuries, often a hip fracture, which then begins a slippery slope, ending for a number of those residents in death. Well, Safer Healthcare now really has established this initiative and, if you will, are providing the infrastructure. And they're working through us at RNAO. We're the lead, the Registered Nurses Association of Ontario. We've really established specific interventions that we're recommending be used in long-term care homes.
The strategy is to identify the residents, and we do that even before they come into the building by looking at the information that we're presented with. And then we start identifying things and equipment that might be needed for that resident once they are admitted. We transfer patients by using Hoyer lifts, and we also transfer them by using sit-to-stand lifts if they're able to follow direction. If they're not able to follow direction, we put a sling under them to support them and keep them safe and protected while we use the mechanical lift to raise them out of the bed and then either position them down into a wheelchair or into a shower trolley system. The equipment that we use for a lot of them are things from mattresses at the side of the bed, should they maybe tumble out of bed. We keep other things in place, strips on the floor, so that the area right beside their bed gives them a tacky feeling and they don't slip so readily. Hip protectors, so that if they fall, they have extra padding on their hips. By giving people some physiotherapy, we're hoping to keep their range of motion working. Once again, this gives them that ability to weight bear on their own, gives them that dignity to move around the building on their own. For people that can't weight bear and have to sit in a wheelchair, then we teach them to foot propel. And they are able to stay comfortable in their wheelchair and supported in their wheelchair, but they're also able to mobilize around the unit just as those that are up walking do. Strapping people down in the chair or in the bed would certainly be a restraint and would certainly increase agitation. We've absolutely found that to be true. So that falls into our least restraint area, and we do not restrain people in any physical way.
The healthcare providers who work most closely with the residents, they generally tend to be healthcare aides or personal support workers. And we really want to target this collaborative to reach those care providers, because unless they're engaged and fully participate, the change won't happen at the point of care. So the comment often is, oh, we can't do one more thing. So I think often when we introduce new initiatives, rarely is there a discussion about what can we let go now, and what are we doing that isn't effective, that we shouldn't be. So we really recommend that those who are right at the point of care become involved in the collaborative.
And I think one of the big things that we do here is have an interdisciplinary falls meeting where we problem solve, and sometimes it just takes, the different healthcare disciplines to come up with some very simple solutions.
Now, a collaborative then is an opportunity for teams within a long-term care facility to come together and make a commitment to work on reducing falls. And they do that really by starting to look at measuring what is the incidence of falls, looking at using some new interventions and monitoring what the impact will be. And with a collaborative, you have the opportunity to work with teams from other settings as well. So together you really work on trying to make the best quality care possible in your organization.
And by just sitting down and having those meetings, putting all of our thoughts together, someone's always able to come up with another angle and approach the fall risk in another unique way.
Well, the big high five would come if we felt that we could see a reduction in the incidence of falls. If we hit our 40% target, which we're really excited about, that would be just tremendous.
I think it's very, satisfying from a professional point of view, where when we've known that we have made a difference in their safety and their quality of life and their physical ability.